everyone, welcome to our latest presentation. It is a journal published in Lancet Respiratory Medicine in August 2021. Awake prone positioning for COVID-19 acute hypoxemic respiratory failure, randomized controlled multinational open label meta trial done by Airman, G. Lee, Ebera et al. All of us know that patients who are severe ARDS and intubated, we do prone positioning for them, and it has a mortality benefit and it definitely improves oxygenation. But patients who are not intubated, we also advise prone positioning for them, that is awake prone positioning, and we see there is improvement in oxygenation. But we don't know whether actually there is any benefit. There is paucity of large-scale RCTs. This prone positioning is incorporated into clinical guidelines and expert consensus statements. It has been a research priority by the Surviving Sepsis Research Committee. So the aim of this study was to determine whether awake prone positioning reduces the rate of treatment failure, which is defined as death or intubation at 28 days in patients of severe COVID-19 pneumonia having hypoxemic respiratory failure who require respiratory support with high flow nasal cannula. Coming to study design, it was a randomized controlled open label meta trial. From 6 countries, hospitals were involved: Canada, France, Ireland, Mexico, USA and Spain. The study period was 2nd April 2020 to 26 January 2021, which was coinciding with the peak of pandemic. Total of 2,350 patients were assessed for the eligibility. Out of them, 1,126 underwent randomization, 5 withdrew consent after randomization. Collaborative prospective meta-analysis of individual patient data from each center and trial was done. Inclusion and exclusion criteria and the planned intervention were harmonized across all the centers. The primary and secondary outcomes of the trial were agreed prior to the study initiation. Inclusion criteria: adults, COVID-19 pneumonia patients, acute hypoxemic respiratory failure, getting support with high flow nasal cannula, PO2 by FI2 ratio less than 300 or SPO2 by FI2 ratio of less than 315. Exclusion criteria has been patient with a constant SPO2 less than 80, even with FI2 support of more than 0.6, signs of respiratory fatigue like PCO2 more than 50, respiratory rate more than 40, pH less than 7.30, and immediate need for intubation, patients with ultrasensorium and who are unable to protect their airway, hemodynamic instabilities with requirement of vasopressors, unable to collaborate with HFNC or awake prone positioning, agitated patients, patients having BMI of more than 40 and pregnant patients. How did they do randomization? They divided patients into 2 arms. One is intervention, that is awake prone position arm, and another is standard care control group. Block size sequence of 1:1 was generated by computer. Allocation concealment was done by online randomization or on-site opaque envelopes. The trial was non-blinded. Patients in awake prone position group were instructed and assisted to lie in the position for as long and as frequent as possible every day. The duration of each prone session was recorded by the bedside nurses and it was supervised by doctors. High flow nasal cannula was initiated at the maximal tolerated flow setting, that is 60 liters and FiO2 of 0.6. The FiO2 target was titrated to maintain SPO2 between 90 to 92%. The study endpoints being weaning from high flow nasal cannula, discharge from hospital, or intubation or death. The predefined criteria for tracheal intubation were provided in both groups at the trial level. Primary outcome is treatment failure within 28 days of enrollment, that is defined as intubation or death. Lot of secondary outcomes were assessed, that is intubation at 28 days, mortality at 28 days, use of non-invasive ventilation, length of hospital stay, time to high flow nasal cannula weaning with patients with treatment success, time to treatment failure, time to intubation, time to death, duration of invasive mechanical ventilation in intubated patients who survive up to 28 days, the mortality in invasively mechanically ventilated patients. Coming to statistical analysis, the meta trial was designed to show a superiority of awake prone positioning over standard care with 90% power and one-sided type 1 error of 0.025. Interim analysis was done after every 200 patient enrollment. The sample size was taken 1000 to provide a 90% of power. So there was total 4 interim analysis. Relative risk were estimated for the primary outcome and all the binary outcomes in a mixed effect log binomial model with a random effect on the individual trial. All the time to event outcomes were compared using survival analysis. The proportional hazards assumption was checked by a visual inspection of the Kaplan-Meier curve. The primary outcome and mortality were analyzed in a Cox proportional hazard model. Mean difference was estimated for duration of hospital stay and was analyzed in a mixed effect linear regression. All the estimates were reported with a two-sided corresponding confidence interval of 95%. Subgroup analysis were done between severe to non-severe hypoxemia, that is PF ratio more than 150 to less than 150. All the analysis were done with R software version 3.6.3. This is a table. We can see 2350 patients were first enrolled and screened for this study. Out of them, 1224 patients were excluded, mainly due to refusal or non-consent. 329 patients they required immediate tracheal intubation. 157 patients had contraindication to prone positioning. 143 patients had BMI more than 40. After excluding these patients, 1126 patients were randomized. Out of them, 567 patients were assigned to prone position group. 559 patients were assigned to standard care group. Finally, after withdrawal of consent, 564 patients in the 28-day intention to treat analysis in the intervention group, 557 patients in the standard care group. Coming to the demography table, demographically all the parameters were comparable between standard group and intervention group. Majority of patients were male patients, 67%. Age was around 60 years average. BMI was around 30. Respiratory rate was around 24 average. Mean arterial pressure was around 88. SpO2 by Fi2 ratio was around 147. That is severe hypoxemia. Most patients were recruited from France, Mexico and USA. Maximum patients had obesity, diabetes and chronic heart disease as the coexisting illnesses. More 88% of patients got glucocorticoids for the treatment of COVID-19, and the treatment site was 60% in ICU, 35% in HDU. Coming to the results, the median time from hospital admission to enrollment was 1 day in both the groups. In the intervention group, the median daily duration of awake prone positioning was 5 with interquartile range of 1.6 to 8.8. In Mexico, maximum patients had daily awake prone position of around 8.6 hours, and the least hours in Spain, that is 1.6 hours. This is a table showing the outcomes. The primary outcome being treatment failure at 28 days, 40% of patients in awake prone positioning group and 46% of patients in the standard care group had treatment failure. The relative risk of 0.86, which is significant. In the secondary outcomes, intubation rate was 33% in the intervention group and 40% in the standard care group. It shows there is definite reduction of the intubation rate in the intervention group. Mortality at 28 days in all patients, it was 21% in intervention and 24% in standard care group, and in mechanical ventilated patients 43% in the prone position group and 44% in the standard care group. So it shows there is not that much of difference in the standard care and intervention group in terms of mortality. Coming to the time to event analysis, in the median days, treatment failure occurred in the 2 median days in intervention group and even in standard care group, but the hazard ratio is 0.78. So definitely there is a benefit in terms of treatment failure in intervention group. Patient in intervention group had 2.3 days of median 2.3 days required for intubation, and in intervention group the median days was 2 days. So in intervention group they were early intubated. The hazard ratio was 0.75, which is significant. Death was median days 12 in intervention group and 14 in standard care group. Non-invasive ventilation in 2.3 median days, standard care group patients required this, and in after 3 days in intervention group. But weaning of high flow nasal cannula, patient within 6 days could be weaned from nasal cannula in standard care group, comparable with 6.9 days in awake prone position group. The mean duration of hospital stay in mechanical ventilation were comparable between the two groups. This is a Kaplan-Meier curve showing the treatment failure. We can see there is definite benefit of intervention group over standard care group. The hazard ratio is 0.78, P value is 0.006, which is significant. At the end of 28 days, 341 patients in the awake prone position group did not have treatment failure, and 298 patients in standard care group did not have treatment failure. This is a forest plot showing the effect of intubation or death, that is primary outcome. Clearly it is seen in all the centers and all the countries there is a bias towards intervention group. The relative risk is 0.86, the confidence interval from 0.79 to 0.98. So it is statistically significant and there is no heterogeneity in any of the studies. Again, in this Kaplan-Meier curve, we can easily see in the intervention group there is less chances of intubation throughout 28 days than in standard care group. 341 patients did not require intubation in awake prone positioning group, and 298 patients did not require intubation in the standard care group. This forest plot showing patient in awake prone position group have less intubation comparable to the standard group. In terms of mortality, there is not that much of significance difference in the standard care and intervention group. The P is 0.2527, which is not significant. Hazard ratio is 0.87. So definitely there is clinically some benefit is there, but statistically non-significant. You can see this. There is no benefit as it is touching the midline. In some centers there is benefit towards standard care group, in some centers there is benefit towards intervention group. Coming to the weaning from nasal cannula, patient at 28 days, 5 patients could not be weaned from nasal cannula in standard care group and 1 patient could not be weaned from nasal cannula in intervention group. But the early days of nasal cannula weaning was possible in standard care group, the reason being not known. In subgroup analysis, in less severe patients, there is no benefit of any intervention, but in severe patients, that is PF ratio less than 150, there is definite some benefit of awake prone positioning. Coming to the effects of proning, we can see 1 hour after proning, there is increase in the SpO2 by FiO2 ratio, decrease in the respiratory rate, increase of the ROX index, which is SpO2 by FiO2 by RR, and it is maintained up to after 30 minutes of proning and even up to 1 hour, then gradually it again decreases. Treatment failure occurred in 17% of patients who remained prone at least 8 hours per day and 48% of patients who remained prone less than 8 hours per day. It is a graph showing the same. Our prone position duration is increasing from 8 hours, the chances of failure is decreasing. We can easily see in this bar diagram. Coming to the strengths of the study, large sample size and adequate power. It is a multinational study. It has a well-defined population and treatment protocol was uniform. It had a faster setup due to pandemic. They could get patients easily and within 5 to 6 months, and it had a lower cost. There are some limitations also. The study could not be blinded as it was an open label study. There are frequent protocol violations. 10% of patients in standard care group also remained prone, and this could have influenced the efficacy of the intervention in the results. And there is slightly different inclusion criteria among countries. Coming to the conclusion, awake prone positioning appeared to be a safe and procedure and had a favorable effect on the primary composite outcome of intubation or death within 20 days of enrollment. The adverse effects of prone positioning, like any cardiovascular events or any catheter removal, were very mild, less infrequent, and it was same in both intervention and non-intervention group. So our take-home message will be, definitely we should suggest awake prone positioning in acute hypoxemic respiratory failure patients of COVID-19 who are getting high flow nasal cannula. Thank you.